Good morning, everyone, and thank you for joining our webinar, Enhancing Care Transitions and Medication Safety. Before we get started, I'd like to go over a few housekeeping items. This call will be recorded for training purposes. The phone lines will be muted for the duration of the presentation. However, we'd like to remind the speakers to unmute their lines by pressing #6. We will take questions at the end of the presentation. I will provide you instructions on how you can ask a question over the phone or pose a question in the chat box. Please make sure to send questions to all attendees. At the conclusion of the webinar, I'll provide you with details on how you can access today's recording. Margie?
Thank you, Nayara. Next slide, please. Good morning, everyone, and welcome to the webinar. My name is Margie Giuliano, and I'm the Regional Medication Safety Lead for the New England QIN-QIO. Today, we're going to be exploring enhancing care transitions and medication safety. Specifically, we will be highlighting some of the efforts that the QIO is proud to support across rural New England. Next slide, please. It's important to note that today's speakers have no relevant conflicts of interest to disclose. Next slide, please. So let's test out our chat feature. Can everyone please type in your name and your role and organization and what state you're from? Thank you. Next slide, please. And while you're doing that, I'm going to review our learning objectives for today. So upon completion of this session, participants will be able to evaluate how data can help inform intervention, selection, and implementation progress, be able to identify the role medication safety can play in transitions of care, and we will be able to describe key elements for successful care transitions in rural communities. Next slide, please. Again, using our chat feature, we're really interested in understanding what you are hoping to gain from today's session, so please let us know by chatting in. I'm now going to turn over the presentation to my colleague, Lynn Chase, who's the New England Regional Task Lead for Care Transitions. Lynn?
Great. Thanks, Margie, and welcome to you all. We're hoping to have a very informal learning session, and by informal, what I mean is we want to hear from all of you. We don't want you to be just attendees. We want you to be active participants. We want you to share what you're currently doing, what you're struggling with, and any lessons you've learned along the way. Before we hand it over to 3 providers that we are fortunate to work with, I wanted to spend just a minute to talk to you about what the QIN-QIO is. CMS contracts with 14 organizations or quality improvement networks across the country. And in each state, there is an organization that serves as the quality improvement organization. We are the quality improvement organization for the 6 New England states: Maine, Vermont, New Hampshire, Massachusetts, Rhode Island, and Connecticut. And the goal of the QIN contract is to improve the quality and efficiency of health care for all Medicare beneficiaries. Next slide, please. We are contracted in 5-year periods. Our current contract started on August 1st of 2014 and runs through July 31st of 2019. We're working in really 3 key areas. We're working with eligible clinicians and focused on prevention, so improving heart health with cardiac hearts and million hearts. We work with clinicians, and we also work with home health agencies on that. We're working with physician offices and communities to improve diabetes self-management and diabetic outcomes. Finally, with physician offices, we also support quality payment programs, helping them understand what the requirements are and positioning themselves to receive the maximum incentive penalty, maximum incentives, and or at least avoiding any penalties. We also work with nursing homes. We work with 75% of the nursing homes across New England, and we're very pleased to have them on board. We're working with a smaller subset of nursing homes to reduce CDI and getting them reporting to NHSN. And finally, we work in the community, and we work with the community on a few key areas. One is community antibiotic stewardship. It's a new effort. We're lucky to recruit emergency departments, federally qualified health centers, and physician offices to begin to implement the core elements of antibiotic stewardship. We're working with providers of all types, so hospitals, home health agencies, nursing homes, and long-term service and support to better improve care coordination, so care transitions, and also with a focus on medication safety. And with that, I'm going to go to the next slide. Thanks. So care transitions, as I suspect most of you are aware, the way we define it is when a patient moves from one healthcare setting to another. Currently, about 1 in 5 Medicare patients, when they are discharged from the hospital, return back to the hospital within 30 days. Next slide, please. So back in the 1950s, when my grandfather was a physician practicing in central Maine, people went into the hospital, they were followed by their physician, and then they went home and they either went back to that physician's office, or at that time, the physician went back to see them at their home. Next slide. But a lot of things have changed since the 1950s. The patient has become more complex. They have multiple comorbid conditions. They are on multiple medications, many taking 9 or more. We are living longer, and there are more available treatments. The biggest area, I think, of opportunity is the socio-economic factors that are impacting health outcomes. Next slide. And we said the system is more complex. It's not just one provider, it's multiple providers, it's the hospital, it's the nursing homes, the assisted living sites, EMS, we have palliative care, and hospice. And it's trying to connect all of those providers to help support the patient. Next slide, please. So how do we fix this? Next slide. In the QIO work, we're really working with providers on 3 key areas to help support their efforts either within their facilities, their own organizations, or connecting with others with whom they share patients. The areas that we're exploring have to do with improved information transfer or communication, making sure that when a patient is transferred to the ED, that the information about that patient goes to the ED clinicians. And when they're transferred out of the hospital, that the PCP has that information. We're working on engaging the patient and or their caregiver into the care team. So patient and caregiver activation. And finally, we're working on standardized clinical processes, or what we used to call care paths. Next slide. Margie, can I turn it over to you to talk a little bit about our medication safety work?
Thanks, Lynn. You know, taking into account all of the issues that Lynn just described, the patient being different, the system is more complex, we also have to add in the fact that medication regimens have become more complex. As a matter of fact, it's not even just the regimens, but the drugs themselves have become more complex. When you start thinking about all of the specialty drugs and the genetically engineered medications. So in order to understand the importance of addressing the issue, we first need to realize the scope of the problem. So while adverse drug events have their biggest impact on the patient, they're also a major driver in healthcare expenditure. Looking at the statistics, you can see that ADEs account for 1/3 of all hospital adverse events. They cause approximately 280,000 hospital admissions annually, and hospital admissions related to adverse drug events in adults older than 65 was almost 25%. What I see as being the most significant fact is that about a quarter of all ADEs are preventable. So we've been focusing a lot of our work in the area of prevention, and you can really look at this as the low-hanging fruit. Next slide, please. Just to level set, we are using the Institute of Medicine's definition of what an adverse drug event is. So it's an injury resulting from medical intervention related to a drug. As you can see from the diagram, all adverse drug reactions are considered to be ADEs because they do cause some level of harm. When you look at medication errors, only those errors that cause harm are considered to be ADEs. And this is the area to target because this is the area that can be prevented. Next slide, please. I wanted to reinforce that the QIO program is focused on supporting Health and Human Services National Action Plan for Adverse Drug Event Prevention. Within the action plan, 3 drug classes most commonly implicated in ADEs for Medicare beneficiaries were identified. And it's really not surprising that the 3 classes were opioids, anticoagulants, and diabetic agents. Looking at the data that's been shared with us over the scope of this work, it's fair to say that Medicare beneficiaries who are on one or more of these classes of medications are more likely to utilize hospital services. Focusing on better and more standardized opportunities for communication across care transitions will go a long way in addressing the ADE issue. Next slide, please. To that point, the QIO has been supporting providers like you to review and implement evidence-based programs like BOOST, Project RED, and others, and to improve patient safety and outcomes in care transitions. Next slide, please. However, one size does not fit all, and that is the balance that we need to keep, understanding that while there are evidence-based and best practices out there, the solutions will vary by provider type and provider needs. Next slide, please. That being said, it can be done, and it is being done. We're really thrilled to be able to showcase some of the success stories that are occurring in rural New England. At this time, it's my pleasure to pass the presentation to my colleague, Gail Colgan, who is the Care Transitions Task Lead in Vermont. Gail?
Good morning, Margie, and thank you very much for that introduction. I would like to introduce to you Dr. Jeremiah Eckhouse, who is a board-certified family physician who has been practicing for 15 years, previously in Colorado before he came to Vermont. He is the medical director for primary care at Central Vermont Medical Center, an affiliate of the University of Vermont Health Network. Dr. Eckhouse has been working on population health and quality improvement for the last 10 years, and he is currently a co-chair of the Community Alliance for Health Excellence and an ACO Unified Community Collaborative in Central Vermont. Thank you, Dr. Eckhouse.
Thank you very much, Gail. It's my pleasure to be here.
Next slide.
Next slide, please. So I'm going to talk a little bit about a pilot project that we did here focused on congestive heart failure. I'm sure most of you are aware of the significance that congestive heart failure plays in our healthcare system in terms of cost and cost to patients and families as well. And we had as part of a network initiative, we had focused on congestive heart failure admissions and readmissions, and we're working to reduce those within our network. And the initial committee was really focused on inpatient work and transitions of care. And I was really interested in what we might be able to do in the outpatient setting to address congestive heart failure and looking at novel ways to work with these patients to help to reduce primary admissions as well as readmissions. So we focused on developing a population-based intervention and a team. And the team consisted of myself, a physician, a social worker who was identified as a patient navigator. I'll talk a little bit more about what that means in a minute, as well as a panel manager. We worked closely with our home health agency. We had an embedded psychologist in our practice, as well as a health coach from our community health team. Okay, looks like we're on the next slide. Actually, go back one slide, please. Yes, so the intervention. The patients were monitored via panel coordination and scheduled for pre-planned visits on specific disease-oriented days. Patients participated in co-visits with the physician and the patient navigator, and the frequency of those visits was based on the patient's risk factors as determined by myself, and it ranged anywhere from 30 days to 6 months. We also had 2 group visits of 2 hours each, and those were focused on diet, self-management, pathophysiology of congestive heart failure, prognosis, advanced care planning, and mindfulness. We developed patient education materials in conjunction with our hospital and home health agency so that those materials were consistent across the continuum. Our electronic medical record is ECW, and a template was developed to support best practice. We also had a treatment algorithm that was utilized. Transitions of care, including emergency department visits, admissions, and discharges from hospitals, were actively monitored and managed by the team. Care coordination was actively monitored by the team at the time of the visit and between visits as needed. Next slide, please. So we had different roles. As a physician, myself, administering primary medical care, group visits, and team leadership. The nurse was in charge of rooming patients, patient outreach, collecting data, medication reconciliation, and nurse case management. The panel coordinator was important for data management, tracking the visits to the hospital, the emergency department, coordinating meetings, and patient panel management. And our patient navigator, the social worker, was involved in care coordination, social work, and also scheduling appointments. Just a little bit more about the patient navigator. They were actively engaged in care coordination and social work, supporting the patient and the caregivers and the families in all settings, which may have included the home, long-term care, specialty, and primary care offices, as well as community services. Responsibilities included coordination of outpatient home and specialty care, communication with the home health agency when appropriate, monitoring transitions of care, applying screening tools to stratify risk, and communicating back with the PCP, myself, regarding any changes in status or risk categories. Next slide, please. So looking at some of the results from this pilot, this was a small pilot that we did. With these patients, we saw a dramatic decrease in the hospital admissions to the emergency department, as well as inpatient admissions. And you can see those here, both before, 6 months before and 6 months after the intervention. Next slide, please. So what did we learn? Well, it takes a team, and a holistic team-based approach appears to reduce admissions and readmissions to the hospital for patients with congestive heart failure, and may be applicable for other chronic diseases as well. Administering this approach is a team effort which includes the patient. Addressing the severity of the disease is important, and discussing end-of-life issues and advanced care planning is also another component that we incorporated, was a very important component to this pilot. The original pilot that we did utilized a social worker in the patient navigator role. We did repeat the pilot with a second practice using a nurse, an RN, and that pilot has just been completed. So it must be recognized that there are financial constraints to utilizing a navigator in this position, but there are also rewards for the patient that improve quality of life and for the health system that helps relieve unnecessary system burdens. Next slide.
Thank you, Dr. Eckhouse. And I will now turn this over to my colleague, Tim Boyd.
Thank you.
Good morning, everyone. Good morning, everyone. So, my name is Tim Boyd, and I work with many of my colleagues throughout New England. That's at the New England QIN-QIO. And I'm going to talk to you about a collaboration between a pharmacist who is employed by a federally qualified health care center and who was embedded at a critical access hospital to conduct comprehensive medication reconciliation. And that person is Karen Torrey, who's also a pharmacist, and I believe Karen is probably also on the call. Next slide, please. Can I have the next slide, please? Thank you. So, initially, Karen saw 68 patients and conducted a comprehensive med review between September and December of 2016. And because we were sort of in the early stages of this process, we looked at some of the data and then we realized that some of the data didn't really seem to be accurate. We found that almost 53% of patients had discrepancies. Karen had recommended that to the physician telling how to correct the deficiencies. Her recommendations were accepted almost 60%, and she had said that the billets were reconciled 94% of the time. Again, those numbers didn't seem real. So what we did is we then went back and we revised her worksheet to sort of get a better sense of what other data that we needed. Next slide, please. So, the part of the QIO, what we have done to support Karen is we supported the intervention design. We created a measurement strategy, and we created data collection tools, which would be that worksheet that I was describing. And that we also adopted Dr. Stephen Chen out of USC, his MTM tools sort of as a validated tool, and we just sort of modified it for our use. And we've also did a lot of work behind the scenes as far as compiling the data and, as we're doing now, sort of just disseminating the learnings throughout, about the project throughout the region. Next slide, please. So, in essence, what Karen is doing, and that is, when she's at the hospital, she identifies each day that she's in, and she's only there for 24 hours during the week. She identifies all of the patients that are admitted to the hospital that are FQHC patients. She then reviews the medication lists and compares it with the admission medication list. One advantage she has is that she's able to look at the primary care list from the FQHC and compare it to the inpatient list that perhaps the hospitalist or surgeon created at the time of admission. She then identifies the discrepancies and points that out to the hospitalist or surgeon or whatever provider is caring for that FQHC patient at the hospital. Then the patient is cared for, monitored, throughout the stay, and then at discharge, Karen will also go back over, look at that medication list, check the discrepancies again, and to sort of assume or check to make sure that any medications that were modified or changed, added or removed from the patient's list is in line with the clinical documentation for that. And then the patient's at discharge. But another really important piece here is that Karen is also able to follow up with the primary care at the FQHC. And she can also follow up with the FQHC pharmacy or even sometimes community pharmacies within the area. And I think that piece is also critical in really helping to bring this medication reconciliation process sort of full circle while the patient has gone in and out of the hospital system. Next slide, please. So some of the enhanced measurements that we included on this worksheet, and you can read this here, I'm not going to go over all of them, but we're able to break out, the payer source, where the patient was located, whether they're med-surg, ICU, the surgical patients, the number of meds that the patient's taken, the average number of meds, the number of discrepancies, and so on. And a really important one is the number of recommendations accepted. And those recommendations accepted are each medication that Karen brings that was identified as a discrepancy that is brought to the provider, to change, modify. That's one of the outcome measures that we're looking at, is to see how many of those of her recommendations were accepted. Next slide, please. So, sort of a quick glance at the data, and I'm not really going to go over this too much, but in all from September 2016, during the baseline period, through September 2017, we've had a total of 302 patients through the system. So it's actually, quite a big number. And one thing I want to highlight is when we look at patients on a high-risk med, and those are patients who are on any opioid, anticoagulant, or a diabetic agent, we're talking, month to month, pretty much anywhere from, 22% of the patients are on one of those three high-risk meds to upwards of 50% or 64% in one month. When we look at medication reconciliation, patients who are on these high-risk meds, I think, are really, really crucial, because these types of meds can cause a lot of adverse drug events. So being able to identify those patients, I think, would be critical, especially if this model was to spread to other organizations. Even if you just stratify your patients and identify those who might be on a high-risk med, that could be someone that perhaps a pharmacist could look closely at those medications when they are admitted to your hospital. Next slide, please. So, again, looking at the data, from September 2016 through September 2017, the first 4 months in 2016, we just sort of had this up and down list. And again, this was sort of what I would call relatively immature data, because we didn't have a really good worksheet at the time. But since January, we've noticed a steady increase in the number of medications that the providers accepted from Karen. So of 761 medication discrepancies that Karen had identified, that they have been increasingly accepted, or her recommendations have been increasingly accepted. And that just goes to show not only trust, but collaboration between a pharmacist making med recommendations to the hospitalist or surgeon. Next slide, please. So when we look at the percent of medication lists reconciled at time of discharge, again, we're seeing a very positive increase. There are exclusions, however, not only to the previous slide, but also this one here. So if, for example, a patient died during hospitalization, that person would be excluded. Also, if the person was transferred to another hospital or discharged before Karen was able to complete the medication reconciliation and review, those patients were excluded from the numbers. But again, what we're seeing here is a very positive trend upwards on medication lists to reconcile the time of discharge. Next slide, please. We also took a quick look, and just was just a small sample, a 4-month period. I mean, what we were doing was we were looking at the post-discharge utilization. So we looked at emergency department visits, 30-day readmissions, and we found that 16.7% of patients in that 4-month period and that had a ED visit within 30 days. We also found that 9.5% were readmitted within 30 days, which is a pretty good rate. We dove further into this data, and we found that those patients whose med lists were reconciled at discharge, so again, these are patients whose med lists were reconciled at discharge, only 6% were readmitted. So we can't say there's an absolute causation, but it certainly appears as if this type of intervention is showing a positive effect. Next slide, please. So some of the things that we've learned is that med management is critical, and it's critical for transitions. We know not only from the literature, but perhaps many of us know from personal experience that sometimes the meds that the patient comes in on might not be complete, and then when they discharge, it's not like it automatically gets better upon discharge. There's a lot of things that get changed in between. So med management is really crucial in that for patient safety. And communication across all essentials. Many times when a patient enters a hospital for an admission, there may not be communication between the hospital and the primary care initially to find out exactly what meds the patient may be on. So if there's meds missing or the meds are maybe a transcription error at admission, unless there's good communication, those discrepancies may continue to discharge and beyond, which could cause an adverse drug event. So communication is essential. And, pharmacists are key partners. I myself was an emergency room nurse for a long time, and I used to do the initial medication lists for patients who were admitted. I think I know my meds fairly well, but I don't know them clearly as much as a pharmacist knows the meds. And I think that's why they're really key in being able to point out subtle issues with medications that sometimes nurses aren't able to do. And another thing that we really learned, and we're not going to go into this for this presentation, but building a business case is essential for sustainability. Getting someone in, be it a nurse or a pharmacist, even medication technicians, to perform a closer look at medications costs money. And so building a business case is essential for sustainability. And I'm sure we'll be happy to take questions at the end. Next slide, please. And so next is Anne-Marie Day, my colleague in Maine.
Thank you, Tim. This is Anne-Marie Day, and I work on care transitions and medication safety in Maine with the QIO. And I'm going to be sharing with you an initiative to develop a standardized approach to information transfer, and this occurred in a community in western Maine. And as everyone has mentioned previously, that transfer of information is a key piece in helping to reduce readmissions and adverse drug events. Next slide, please. So this initiative arose from the issue that a health system was having was receiving inconsistent or incomplete information upon transfers from nursing homes to the emergency department. So this was creating issues for treatment of the residents, and oftentimes the ED would not receive complete medication or treatment information. So because of this, the health system made improving information transfer an overarching goal for all of their facilities, and they shared this effort throughout the ACO Senior Living Collaborative. However, one community in western Maine took this initiative to the next level, and they decided that they wanted to use a work group to tackle this improvement effort and others as well. Next slide. So they worked on creating the team. The team consisted of the hospital, which was Stevens Memorial Hospital in Norway, Maine, and they involved leadership staff, nursing, and care management staff. The nursing homes were Norway Rehab, Market Square, Maine Veterans Home in South Paris, and Ledgeview, and they also included the emergency medical services and other community partners, which were the Area Agency on Aging and Healthy Community Coalitions, who all came together to meet and discuss the improved transfer communication process. Next slide. So this diverse team came together to decide on a solution to the problem by creating a standardized transfer protocol. The group met and discussed what would work best for the team to improve this process. Here on the slide, you'll see an outline of identified items that were included in the transfer protocol, and these documents were sent with the resident to the emergency department. The resident transfer form that was adapted from the Interact tool, which is a toolkit of interventions to reduce acute care transfers. And this transfer form has important information, including the mental and physical status of the patient, different risk alerts, and who to contact at the facility with questions. It also has the MAR and TAR, which are the medication administration record, and the treatment administration record, SBAR, which is situation, background, assessment, and recommendation. It's a nursing communication form from the Interact. And then the hospital also thought it was very important for all of their staff to be trained on utilizing the SBAR, so they did that as well. Advanced directives, signed codes, and other necessary information is also provided, and all of these are copied into two packets, one for the EMS and one for the emergency department. And so with this packet, the ED has the pertinent information that they needed right away to be able to treat the patient more effective and efficiently. And because of this work group, members now know each other, and they've formed relationships, so they've found that it's easier to reach out with questions, improving both communication between the facilities and the EMS. Next slide, please. So the lessons learned, we've learned from this process that consensus is crucial because there's so many different players. Everyone needs to be on the same page and come up with a plan that meets the needs of all. And this effort really started with the case managers and the nurse champions and the ED. So it's really important to find these champions within your facilities to drive these improvement efforts and include them in the process. The frontline staff doing the work need to be involved since change cannot just be directed from the quality leaders. And one of the main lessons learned we found was that balance is key. It's problematic to have both too much information or too little information. And so initially the ED was getting incomplete information when the patients arrived. And once they initiated this process, they were receiving these tools in both the MAR and TAR. They were getting over 200 pages of information, which was just too overwhelming and not efficient for treatment. So the group came back together and reevaluated the situation and decided that they only needed 3 days of the MAR and TAR for effective communication. And because of this, the group continues to meet quarterly just to resolve any issues that arise, such as this one. And it's also led to a solid foundation for the group to explore other opportunities for improvement. The group now has worked on infusion issues. They've set clinical criteria for urgent needs for transfusion, for scheduled transfusion, to cut back on emergency visits to the ER. The EMS has also been very involved, and now they're bringing education into the nursing homes on topics such as COPD. And they've also created an education process for financial obligations for patients when they are being transported and the patient prefers to go outside of the facility of Stevens Memorial. One of the challenges that the group identified that the nursing home found was changeover in staff. It can be hard, once they've implemented this process. So it's really key to include training about the transfer protocol for orientation of all new staff members. But overall, all the staff has improved this information sharing has greatly improved with both the ER nurses and the nurses in the nursing home feeling that the lines of communication have improved, and they now feel like they're able to reach out to each other to discuss patient care. And so these are the major lessons that we've learned from this collaborative effort, and I appreciate you all letting us share this opportunity from me. So I will turn it back over for questions and discussion.
Thank you, Anne-Marie. Next slide, please. So first, I really do want to thank all of our presenters for sharing their successes. As you can see, there are a lot of exciting projects going on. Now we want to open it up for questions and discussion. Nayara, can you remind our attendees how to unmute the phone line?
Sure. Please press #6 to ask a question over the phone, or you can put your question in the chat box. We will be taking as many as we can, but rest assured that if we don't get to your questions during the webinar, someone will get back to you.
Thanks, Nayara. Do we have any questions in chat at this point?
Not as of yet.
Okay. So while we're waiting, I guess I'll start off with a question. This is really for the New Hampshire, for Tim's group. Tim, do you think that the fact that Karen, the pharmacist who's embedded at the Critical Access Hospital, because she knows the patient as well, because they're patients of the FQHC, do you think that makes a difference in how she can assess what's best for the patient? I'm assuming she would know a lot of their socioeconomic challenges as well.
Karen, is there any way you could answer that question? If you could unmute your line by pressing *6.
I was hoping that I could stay quiet.
No.
I was hoping I could stay in the background. It's very personal for us, and I think the patients feel comfortable discussing issues when they've seen your face before. It's a real lead-in, and I think one of the biggest examples is a veteran that we knew couldn't afford Lovenox, but we were able to check with the VA, understanding then that there was a procedure to get Lovenox for that patient overnight. It was a big win, and it really enlisted a lot of help between the social workers. So people that you don't think are in the mix are really frontline, and it's very collaborative. It's refreshing in your career course to see such caring. So yes, it is very helpful. In fact, today, again, it was one of our patients in ICU, and I knew the list was totally wrong, and you want that baseline to at least start from correctly to go further. So I did catch that before I got on the phone here. Thank you.
Thanks, Karen. That's great. We have something in chat yet, Nayara?
Yes, we actually have a question from Charles Page. Can you recommend good resources for discharge education on medical conditions? I have some that are fairly basic. Where are the latest ones available?
So discharge education in general on medical conditions, or for specific, Dr. Eckhouse, do you have any? Can you provide maybe some resources?
I wish I could. I think that what we did was we compiled and gathered as many resources specific to congestive heart failure that we could find, and then we made our own. And we've actually, as a network, we've kind of come up with our own design for patient education materials. So but I'm not sure if there's which database people are using specifically.
If I could interject, Pharmacist Letter has a great review on patient education for opioid COPD, and CHF. It's a great checklist. I've discussed it with discharge nurses here at LRA, or the discharge staff here, and that's what we'll be pursuing next. And also, I think it was Margie, maybe Tim help me, it was at our very first meeting that you presented some information on questions to ask, the basic questions in regard to CHF. Do you have a scale at home? Some of the most important issues are right in front of us but not seen, and I can relate to a new process by our facility that now is getting blood pressure costs to patients that couldn't afford them, especially the high-risk ones. And I know that you have a whole list of good ideas for those 3 targeted high-risk areas.
Yes, there's a lot of information on our website that provides a lot of, again, good detail.
I would point to your website and to pharmacist's letter if people are interested in that. But it was very helpful on our side, and that's where I'm pointing my direct conversations this next year with discharge consultation to patients. Thank you.
Thank you. Do we have anybody with a question from the phone line? Okay. Not hearing any. Nayara, do we have another question in chat?
We do. We have a question from Mary Jane. Was there any collaboration with home care agencies in these studies?
Hi, this is Dr. Eckhouse again. We did do some collaboration with our home health agency, and we had some patients that had home health coming into their homes, and so we had some care conferences with home health nurses. We also did an education session for our patients around using telemonitoring and demonstrated what the telemonitor device can do. They hooked me up to the telemonitor so my patients could see how it worked, and it was a lot of fun. So I think we learned a lot about collaborating with our home health agency, and what we were getting before was you might get a report from the home health agency about what's going on, but there wasn't that direct communication, and I think having a patient navigator really allowed the communication to improve, and I was getting a lot more direct information about my patient's conditions. So I think it was an improvement over the status quo.
Thank you. Nayara, other questions?
Yes, we have a question from Holly Brown. Can anyone share success stories on developing communication methods for transitions of care from skilled nursing centers back to PCP?
Hi, it's Dr. Eckhouse again. I don't know if anyone else has an answer to this question, but I will jump in and say that I think having a patient navigator when it comes to working with patients with chronic conditions significantly improves the communication in transitions of care. The patient navigator was getting information about these patients when they were going into the hospital, so she was able to connect with the inpatient facility, even sometimes visit those patients and families when they were in the hospital. So the communication improved dramatically by having that patient navigator following the patient and following the family around to the different areas of care.
Great, thank you. Any questions from the phone lines? Okay, hearing none. Do we have any more questions in chat, Nayara?
Yes, Gail Colgan is asking, how did Dr. Eckhouse handle co-visits?
I'm glad you asked that question. That's a good question. The co-visits were probably one of the most important things, I think, in the success of the pilot project. And most of the time, the social worker would go into the patient visit before I did, so that she was able to get some information about the social circumstances, about the concerns that the patients had. As many of you on the phone know, it's those social issues that really impact the health of our patients with chronic diseases. And so getting information about that was, I think, key to the success for those patients. And I really enjoyed the co-visits because I learned a lot about my patients that I didn't know before. The other thing was that the navigator learned a lot about the disease process of congestive heart failure, learned about monitoring, self-care, disease interventions, cardiology, when do we need cardiology involved, and we had a risk stratification tool that allowed her to see when patients were at higher risk for hospital admission. And she was able to utilize that to then bring more information back to me that was useful in my management of the patients. So that's what we did.
Thank you so much. I'll put one of the questions as well from chat from Adelarada Fatone. Can you expand upon sustainability of the embedded pharmacist doing med reconciliation?
I guess that one would be for me. I'm Karen Torrey, and at this point, we have another year with the collaboration between the regional hospital and ourselves. And there is some suggestion that we will potentially, and please underline potentially, be looking at some assistance from the hospital via a pharmacy tech to do some of the load. It's in the works. So at this point, we are continuing for another year from the FQ side has a grant for another year. So with our, I think Tim can look at the ROI that we have presented to the pharmacy department here, and then that goes up to administration to see if they want a full-time position for that sustainability. Thank you.
That's really exciting, Karen, and actually
it is.
There's a follow-up to that question. Was there a transfer of any duties from case managers?
I just saw that was about to answer that. No, there were not.
Nope. Do we have any questions from the phone? Okay, any other questions in chat, Nayara?
Yes, Mary Jane has another question. Was there any work done with having medication pre-fills completed by home care agencies or pharmacies? If so, how is insurance coverage obtained for this non-skilled service?
If I'm understanding the question correctly, the answer would be the only communication I had with off-site facilities was verifying the med was picked up and the compliance over, say, a 3-month period of time to bring that information to my hospitalist to review and assess. So I didn't talk directly to them for filling. However, I did discover that there is a big question, and it will be one of the new targets in regard to automated complacency. And by that I mean when I spoke with one patient, they said, I use my phone to document all my meds. Oh, yeah, I forgot to update that. That's one target area, as well as going out to a patient and saying, I'm noticing that you won't have refills on this very important med, and do you want me to have your PCP write a new script? And they said, no, I'll wait till my pharmacy does an automatic refill. But I thank you for that question about how do you look at automatic refills and make sure they don't continue meds that are outdated. That would be an additional step that I didn't think about, so thank you for bringing that forward.
Great, thank you. I think we have time for one more question. Again, anything from the phone, Nayara, or something from chat that we can...
Yes, Ramona Benali is asking to all presenters, is there an algorithm or workflow available, or can you share?
I can tell you that I've been asked by the facility for that workflow, and I know my CEO, Ed, has always said we will share any information at any point. It is in its infinite stages because, like I mentioned, they may be utilizing a pharmacist after I leave in the same aspect. So if you want to email me, I can get that to you as soon as it's in its final form. Thank you.
Thank you. Dr. Eckhouse, do you have anything to add for algorithms?
No, I don't really. The algorithm wasn't particularly helpful, and I think in the long run, so I wouldn't want to share that. There's another question there about the risk stratification tool as well, and we didn't find a correlation between the risk stratification numbers and actual risk for admission. We also measured patient confidence and didn't find confidence in self-care, and we did not find a correlation between that number and risk for admission. So I don't know that those particular tools will be helpful for that purpose in the future.
Thank you. Anne-Marie?
Yes, I can check with the facility and see if they have their finalized workflow to share, and then you can definitely check out the Interact toolkit as well.
Great. Thank you so much. So just to try and, I guess, wrap up some of, what some of our key takeaways might be, is that it's really important to have a team approach. It's very helpful, and again, important to have the right people on that team. I think communication was heard loud and clear, and that sustainability can be frustrating, but certainly I think that we're starting to make some headway in that area as well. So I really want to thank all of our presenters today for all of their input. Next slide, please. Just as a reminder, the next webinar that we're going to have in our Med Safety series is going to be held on January 25th, and we are going to be exploring innovative approaches to enhancing care transitions and medication safety for our patients at home. So again, the involvement from home health agencies. I also want to take a minute to thank our rural health partners for presenting with us on this webinar today and for assisting us in all of the work that they do. Next slide, please. For those pharmacists who are claiming continuing education today, the ACPE code is Rural Solutions. You'll be able to enter that information when you complete the session evaluation. Others who complete the evaluation will receive a certificate of attendance. Next slide, please. If you're interested in learning more about our programs or collaborating with us on any of your initiatives, please feel free to reach out to the Care Transition team that is in your state. The leads are listed on this slide for your convenience. At this point, I will turn it back over to Nayara for wrap-up.
Thank you all for a great discussion. I have a few final announcements before we end today's call. As you can see from this slide, we are now on social media. Please connect with us on Facebook and or LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with the link to the evaluation, as well as the link to the event page on our website. The PowerPoint presentation was in your Day of Details email and is posted on the website, and we have added the link in chat. Within the next few business days, a recording and transcript of this webinar will be added to the event webpage. Thank you everyone for attending, and